Welcome back everyone, Dr. Naveen here from UPSC MEDICO. So in this video, we'll try to look at one of the important topic, that is ascitic fluid analysis. Within this, I had seen a lot of questions coming from this particular topic, that is serum ascites albumin gradient, otherwise known as SAAG. When it comes to fluid analysis, in general, we have three different fluids in the body. Pleural fluid analysis, wherein we have a special criteria known as Light's criteria. Okay, this is one topic where a lot of questions come from in MCQ based exams. Next comes our peritoneal fluid, or let's say ascitic fluid. So in ascitic fluid analysis, we have our SAAG criteria, SAAG based stuff. Apart from that, even CSF analysis has got a lot of differential diagnosis questions. In these three fluid analysis topics, a lot of MCQs comes in various entrance examinations. Why they're asking these questions repeatedly? The reason is there is little bit of confusion, because if you take Light's criteria of pleural fluid analysis, we'll be looking at transudate versus exudate. Okay, exudative causes and transudative causes. Coming back to SAAG, it is almost similar to transudative but exudative, but this SAAG is mainly differentiating causes based on whether there is portal hypertension present or absent. Okay, so there is ascitic fluid because of portal hypertension, it will have a SAAG more than 1.1 gram per deciliter. If there is non-portal hypertensive causes of ascites, then you will have SAAG less than 1.1 gram per deciliter. So on this parameter, I had seen a lot of MCQs. We'll discuss this in detail. Just I have given you a gist that this is important topic and this is the focus area. But if you see a case of ascites, okay, if you see an abdominal swelling and if there is fluid dullness and shifting, everything like the features similar to the ascites, if they are present, if the clinical diagnosis is made, then you need to do aspiration of this ascitic fluid, and we call this procedure as paracentesis. So what is paracentesis? Aspirating this ascitic fluid. Usually, one of the important MCQ is the location where we prefer. Okay, the location on the body where you need to put a needle, because whenever you put a needle, you might injure the inferior epigastric artery, which lies close in proximity to the umbilicus here. So that's why this location is not preferred. So outer quadrants are preferred and lower quadrants are preferred. Left is more ideal because it has greater depth of ascitic fluid and also it has a thinner abdominal wall. These two statements are given in Harrison. Why do we prefer left to lower abdominal quadrant for paracentesis? Because it has greater depth of ascites and also it has a thinner abdominal wall. So what is the location? You have to measure from anterior superior iliac spine, 3 centimeters to the right, from there 3 centimeters to the up. So this is the site of insertion of your ascitic fluid needle for aspiration. After aspiration, we will send it for both gross and microscopic examination. Gross or laboratory examination. And gross is the visual appearance, like how does the fluid look after aspiration. If it is turbid, then the cause could be mostly infection or it can be because of any tumor. Okay, if it is white and milky, then we call it as a chylous ascites. Okay, so one of the important biochemical parameter is when you do serum analysis or when you do ascitic fluid biochemical analysis, the triglyceride count is high. That is, you see hypertriglyceridemia when you do ascitic fluid analysis. So the levels will be more than 200 mg per deciliter. It can reach even up to 1000 mg per deciliter. So what is my point of importance here? So you need to understand that there is a condition called chylous ascites, where the gross appearance is white and milky and it is characterized by increased triglyceride levels. Where do you see this? Chylous, lymph. It is related to lymphatic disruption, which is because of trauma, cirrhosis, tuberculosis, congenital abnormalities and tumors. So these are the 5 conditions wherein you see lymphatic obstruction or lymphatic destruction leading to chylous ascites. Now coming back to the dark brown gross appearance is seen in dark brown. This brownish color is because of the biliary tract perforation. Whenever there is a biliary tract perforation, you will see an ascites which is dark brown in gross appearance, and black is because of either metastatic melanoma or pancreatic necrosis. So if there is a necrosis, there is blackish fluid, or if there is malignant melanoma which looks black, melanin is black in color, right? So metastatic melanoma can lead to black appearance of the ascitic fluid. So in this slide, we learned that what is paracentesis, what is the preferred site, and based on the gross appearance, what is the differential diagnosis of an ascitic fluid. But questions are mainly coming from SAAG. SAAG means serum ascites albumin gradient. So for this, you need two values. One, you have taken an ascitic fluid. So measure albumin content of an ascitic fluid. At the same time, take a serum sample and also send it for serum albumin analysis. Okay, so if serum value, albumin value is X minus ascitic value is Y, so this X minus Y value is SAAG. Normally it can be either more than 1.1 gram per deciliter or less than 1.1 gram per deciliter. We'll come back to this. So the value that you need to remember is 1.1. That is SAAG. AA means 1.1. If it is more, if it is less, what is the difference? We'll come back to that. But you have to remember that SAAG means 1. A means 1. So the value is 1.1. The value to remember is 1.1. So what does this value reflect? If the value is more, that means SAAG is more. That means serum ascitic albumin gradient is more. That means if it is serum albumin minus ascitic albumin, if the value is more means maybe the serum albumin value is high or the ascitic albumin value is low. The protein content is low. That means it is more or less transudative kind of fluid. So transudation occurs when there is hypertension. So that indicates if the value is more, that means there is more pressure in the hepatic sinusoids. What is an hepatic sinusoid? You see, this is a portal triad. In the portal triad, between the portal vein and the bile duct, you can see the hepatic sinusoid here. The exchange of fluid occurs here. So if I can zoom in, okay, this is the liver parenchyma. There is a space of Disse where you see Kupffer cells and all. Then this is the vaginal lumen. So inside this lumen, you have a portal pressure, that is hepatic sinusoid. So the pressure in the hepatic sinusoid or the pressure in the hepatic vein, that is hepatic venous pressure gradient, is reflected by this SAAG. If it is high means it is portal hypertension. If it is low means it is not portal hypertension. So I can say that, I can confidently now say that when I look at SAAG value, it reflects the hepatic venous pressure. The more is the pressure, the more is the portal hypertension. So I can distinguish ascitic caused by portal hypertension versus non-portal hypertension based on the SAAG value. If it is more, that means if the SAAG value is more than 1.1 gram per deciliter, it is because of portal hypertension. If it is less, it is non-portal hypertension causes. Like you have a biliary leak. Biliary leak means, I had told you, it looks dark brown in color. Okay, biliary perforation leading to biliary leak. Similarly, you have nephrotic syndrome where patient will have periorbital puffiness and proteinuria. Then it can be pancreatitis. One of the characteristic biochemical finding in pancreatitis is, apart from SAAG value being low, pancreatitis is characterized by increase in ascitic amylase content. Amylase is more than 1000 milligram per deciliter. Then we have peritoneal carcinomatosis and tuberculosis. The characteristic biochemical finding in tuberculosis is increased adenosine diaminase. So it is valid even for CSF, it is valid even for pleural cavity or pleural fluid effusions. So wherever there is a fluid and it is increased because of tuberculosis, ADA levels are high and it is highly sensitive marker for identifying TB based effusions. Okay, so these are 5 important causes where SAAG is low. Now coming back to increased SAAG value, that means I already told you it is because of portal hypertension. There is so much of pressure in the hepatic sinusoids. To combat that, there is also increase in oncotic pressure. So the protein is not going into the ascitic fluid, it is staying back. So the ascitic fluid values will be a little low. But now there are 2 ways of looking at it. Yes, the SAAG value is high, but when you look at the protein value, if the protein value is also high, that means ascitic protein value is good. That means the exchange is still maintained. See, there is increased portal pressure. To maintain that, there is some bit of protein, oncotic pressure acting here. But if this hepatic sinusoids are damaged, if this layer is damaged, so this kind of this layer damage occurs in cirrhosis of the liver, late stages of Budd-Chiari syndrome, and in case of massive liver mets. If it is damaged, the protein exchange does not occur and the ascitic fluid does not contain proteins. That means though the SAAG value is high, ascitic protein value is low. That indicates damage to the hepatic sinusoids, and these occurs in cirrhosis of the liver, in late stages of Budd-Chiari syndrome, which is characterized by hepatic vein thrombosis, and also in massive liver metastasis cases. Because there is disruption to the hepatic sinusoids, the ascitic protein is not entering from the area into the ascitic fluid because there is damage to the barrier. If barrier is okay, because of the high pressure, there is transfer of protein into the ascitic fluid. So the ascitic protein is maintained or it is increased. It is more than 2.5 gram per deciliter. So this indicates there is normal hepatic sinusitis, and the causes are heart failure, constrictive pericarditis, early stages of Budd-Chiari syndrome, IVC obstruction, and sinusoidal obstruction syndrome. Any obstruction to the hepatic sinusoid, the flow gets hampered and the pressure increases, and there will be a little bit of protein which crosses into the ascitic fluid. So that's why ascitic protein content increases. So ascitic protein more than 2.5 gram per deciliter, normal hepatic sinusitis, causes are heart failure, constrictive pericarditis, early Budd-Chiari syndrome, IVC obstruction, and sinusoidal obstruction syndrome. Now when you look at this heart failure, there is another biochemical parameter which might be raised, that is increased proBNP, brain natriuretic peptide. It increases whenever there is heart failure, whenever there is an atrial stretch. The atrium releases this special biochemical element, that is BNP. If you can detect raised BNP in a case of ascites where SAAG is high and ascitic protein is high, then you can happily conclude that this ascitic effusions or this peritoneal fluid accumulation is because of the heart failure. Okay, when SAAG value is not giving an exact diagnosis, the gold standard always is either you go a laparotomy or laparoscopy, then you do some peritoneal biopsy and send that sample for histology and culture. So it is mentioned clearly in the Harrison that the gold standard for identifying the cause of ascites always is either doing laparotomy or laparoscopy, then take a peritoneal biopsy and send it for either histology or culture. This is the gold standard. Okay, so these are the causes which you see in SAAG. Now let's try to solve a few of the MCQs which were asked in UPSC CMS exam to have a fair idea what kind of questions are coming from this topic. Now you see which of the following ascitic fluid analysis is most compatible with diagnosis of ascites secondary to portal hypertension. That means the SAAG value should be more than 1.1 gram per deciliter. Okay, right? It should be secondary to portal hypertension. Apart from that, the ascitic fluid protein, okay, the ascitic fluid protein should be more than 2.5 gram per deciliter. So the correct value here is the SAAG value is more than 1.5 gram per deciliter and ascitic fluid protein should be more than 2.5 gram per deciliter. So this is the ideal value which indicates that most of the times the diagnosis of ascites is secondary to portal hypertension, which can be caused by lot of things like heart failure, IVC obstruction, sinusoidal obstruction. In very severe cases, the value will be less, like liver cirrhosis, Budd-Chiari, or massive liver metastasis. Okay, so this should be the correct answer for this question. When serum ascites to albumin gradient is less than 1.1 gram per deciliter, then which of the following causes of ascites may be considered? Yes, infection, TB, malignancy, cardiac ascites, and portal hypertension. So these are wrong options. In cardiac ascites, that is heart failure, you will see value more than 1.1 gram per deciliter, portal hypertension also more. So the correct answer here is 1 and 2. Okay, 1 and 2. This is 2024 UPSC CMS question. So now you know how to apply this concept of SAAG in solving MCQs.